Welcome everyone to today's Project ECHO, Statewide Antimicrobial Stewardship OPAT and COPAT. So I'm going to start with a COPAT presentation. And this first case is a bone and joint infection. So if it's okay with you, I'm going to give the patient's pertinent history of present illness, and then we'll go into the proposed antimicrobial regimen. The patient's medical history includes a lumbar spine degeneration with stenosis, for which she underwent lumbar spine surgery and had hardware inserted in July of 2023. And this was complicated by wound dehiscence. So she presented to an outside facility where CT imaging on August 14th showed a large fluid collection. She was transferred to our facility for evaluation by orthopedic spine surgery. Blood cultures on August 14th grew Staphylococcus epidermidis. It was just in one of two sets, so this was consistent with contamination. She underwent wound irrigation and debridement with a wound vac application on August 15th, and intraoperatively findings suggested that there was superficial and deep infection. And operative cultures grew MRSA in 2 of 2 specimens. At the time of evaluation, she was receiving vancomycin and rifampin. So moving up to which antimicrobial therapy and why. So we're proposing to use linezolid at 600 milligrams by mouth twice a day, and rifampin 300 milligrams by mouth twice a day. And the reasoning is linezolid has very good MRSA coverage with high 100% bioavailability, and rifampin is beneficial in combination with an anti-staphylococcal agent in the setting of routine hardware to prevent biofilm formation. And for this particular case, it was planned to also transition to doxycycline oral suppression following completion of treatment because operative cultures were positive in the setting of hardware retention. So you can scroll down. So medical history is listed for you. It's otherwise pretty not significant. Medications are here as well. So on the medication list, I just wanted to point out medications with potential drug-drug interactions. So we see buspirone and citalopram, as well as sumatriptan. So these all in combination with linezolid have potential to increase the risk for serotonergic-related effects. Sumatriptan here was just used as needed. The other ones were regular medications. So in our practice, we've been counseling patients about the potential for interaction and monitoring them closely, and they've done quite well. The other interaction here is that buspirone may have its effectiveness decreased by rifampin. So in this case, we let the patient know. And just kind of moving on, allergies not significant. No history of alcohol or illicit drug use. Patient had a prior history of smoking for social history. So on physical exam, the patient was afebrile, looked well, clear breath sounds, regular rate and rhythm. Did have a dry dressing. So at this point, the wound vac, by the time we met the patient, was an incisional wound vac, had been removed, and dressing was being changed by the orthopedic service, and had intact motor and sensory function. So for labs, maximum CRP was just mildly elevated at 8.7, and it hadn't been repeated yet at the time of evaluation. So I already shared with you really the microbiology, as well as the outside imaging, and the patient just had a peripheral IV line. So the main questions about this case, I proposed an oral antimicrobial regimen, but would people in the audience feel comfortable with early intravenous to oral antimicrobial transition? So this is a spine hardware associated infection.
Excellent. Thank you so very much for that, Joy. Does anybody have any following questions?
The other questions I had on here just were, would you add rifampin and why? And I kind of shared already that it is effective or useful for preventing biofilm formation in the setting of routine hardware. So it's used here in combination with linezolid for that, which has anti-staphylococcal properties. And then the last question I had was, how long would you treat and why? If anyone in the audience wants to contribute, and then after that, I'll share just, I'd follow up how the patient was doing.
Guess I can hop in from our point of view. So the rifampin makes sense for sure for retaining hardware. think what's interesting about that, is that I'm thinking of a recent actual OPAT patient where we had a patient on bank and rifampin in a similar scenario and transitioned them to adaptive medicine, which does have some intrinsic biofilm activity on its own. So there was a question there about whether or not we needed additional rifampin, but this isn't very classical case. And then duration wise, I think our standard probably is going to be 6 weeks of therapy, but just from prior experience and following patients, sometimes the spinal hardware patients can need a slightly longer duration, especially in something like the RSA, depending on their clinical picture around this.
In her case, we did propose like a 4 to 6 week duration, with the thought that the infection, the hardware was going to be retained and she was going to go to oral suppression. And her CRP did normalize very quickly, and started out kind of low to begin with. So had surgical debridement and then was going to be placed on oral suppression. So we had offered a shorter course, but the patient actually had already gotten her rifampin, which she did have some insurance coverage, but did have to pay for her supply, and felt more comfortable with the 6 weeks. So she did get a full 6 week course. The end of treatment CRP in this patient was 1. Again, it did normalize prior to the end of 4 weeks. She completed 6. And she was recently seen in follow-up about 2 months after finishing her oral antimicrobial treatment course, when she was on doxycycline oral suppression and doing very well, with no evidence of persistent or relapse infection. Yeah. So that's the first case that I had. What do you think about time, Elizabeth? Should we let Dr. Johnson present, or do you want me to share any highlights of the other? Up to
We
you.
we have the 2 cases. Did you want me to go ahead and do your second case, or go to do Jessica's first?
Whatever you think as far as time. Might go together if you think we have time.
Yeah.
I can go for the next one in just about 5 minutes.
Absolutely. I think we can definitely do that for you. Give me 1 second. I'll pull that right up for you.
It was meant just to be another example, and then also to be used only if we needed to generate some more discussion. So I'll go through this in 5 minutes or less. But similar bone and joint case, again, treated with COPAT. So this patient had previously undergone a left total knee arthroplasty reimplantation in August of 2023. She developed wound dehiscence and associated fever, chills, drenching night sweats, and a decreased appetite. And she was already on doxycycline oral suppression. And I don't think I shared that she is a 55-year-old female who follows here in our orthopedic ID clinic. So this patient had prosthetic joint culture from a left knee arthrocentesis on November 11th. It grew Streptococcus agalactiae. And then she underwent left knee debridement, antibiotics, and implant retention, which is a DARE procedure, on November 14th, when operative cultures grew SSA in 6 of 7 specimens, as well as the Streptococcus agalactiae in 2 of 7 specimens. And she was receiving ceftriaxone and doxycycline at the time of evaluation. So the proposed antimicrobial regimen here was cefadroxil 1 gram by mouth twice a day, so the higher dose, and then rifampin 300 milligrams by mouth twice a day. And the thought or reasoning is that cefadroxil has good MSSA coverage with high, greater than 90% bioavailability. And rifampin, again, is beneficial in combination with an antistaphylococcal agent in the setting of retained hardware for biofilm formation. So this is just another example. We think a lot of vancomycin and rifampin, or even use of daptomycin and rifampin, linezolid rifampin, but also that cefadroxil targeting MSSA can be used in combination. And this patient then was later, or had a plan to transition to cefadroxil at the lower dose, the 500 milligrams by mouth twice a day, oral suppression. And the reasoning there was that her MSSA isolate was doxycycline resistant. So just very briefly more about her medical surgical history is outlined here. Did have rheumatologic conditions, including rheumatoid arthritis, lupus, that had diabetes, obesity, cervical spine surgery with hardware. And then she had bilateral knee, total knee arthroplasties, and the left one had become kind of chronically infected, and her surgeries are outlined here just in case anyone would want to see them. So just moving on to the medications, again, just to highlight the ones with the interactions. So this patient was on bupropion or Wellbutrin for smoking cessation, as well as escitalopram. So both of these here, the learning point was could have their effectiveness decreased by rifampin. And in her case, smoking cessation was something that was felt to be very important for her recovery postoperatively. So her dose of Wellbutrin was increased on discharge. And here, allergies, social history, really not significant. On exam, chronically ill appearing, and at this point, she had a brace over her left knee with Chemovax and a wound vac in place. There are some pictures at the end of this case, just you could see the wound to hit since preoperatively, and I probably should have shown that when I was talking about her case. If you scroll all the way down, as well as postoperatively, again, this was an incisional wound vac she had. So this is the preoperative picture. You can see the wound had kind of opened on the medial portion, and there's some drainage from the inferior portion. And then at the bottom here, this is once her incisional wound vac was removed postoperatively. So you can scroll back up just for a minute. Thank you. So her CRP here, it's a little bit higher on the screen, but was a maximum of 200 and about 49. It had come down to about 58 when we saw her. And then the microbiology, I kind of already outlined. We had growth of both MSSA that was doxycycline resistant as well as Streptococcus lactiae. And she had just a peripheral IV line when she was evaluated. So same questions, you know, would anyone else feel comfortable with early intravenous to oral antimicrobial transition? Why should rifampin be added? And that teaching point is kind of the same as the first case. And then are there any drug interactions? I shared the ones with rifampin here. So would anyone else be comfortable or have reservation to add rifampin in her case, or do we think it's a good idea? And then we'll move on to Jess's case.
Feel free to chat in or unmute, please.
Yeah, Joe, you probably mentioned this. I didn't get a chance to look at what her medicine list was, but just another point to always review the medicine list because of that rifampin interaction with a lot of agents. The one that always comes to mind, of course, is Coumadin, and considering a different anticoagulation if possible.
Thank you. And that's a great point. She wasn't on anticoagulation, but that is one that we, frequently have to consider and factor in.
Thank you so much. Anyone else? All right. Thank you so very much for that, Joy. We will go ahead and move forward with Jessica if you don't have any further questions.
Sure. Can you all hear me okay? Great. Sorry for zooming in a little bit late. Anytime there's technical difficulties, I'm always having technical difficulties at baseline, so I apologize. The case that I'm going to review, my thought would be talking about how your need for a polymicrobial coverage can change based on what's found with the patient's outcome. So in brief, I'll just mention the key points of this case again to kind of keep time in mind and ask any questions that do come up as I speak. So this was a 53-year-old male who had a progressive skin soft tissue infection. He had actually been admitted at an outside facility. The night before his admission, he had noted a small kind of painful red bump on his left index finger. Didn't think much of it, but by morning, this had progressed to his entire finger, dorsum of his hand, and wrist. He was actually brought in by family because he was altered. And when he came into the ER, he was definitely in septic shock. So had a true fever of 102, 103, hypotensive, tachycardic, was noted to have just diffuse erythema of his hand with almost like vesicular-like lesions that were oozing, as well as pus. Empiric antibiotics were started of vancomycin and clindamycin. and he was taken to the OR emergently and underwent 4 INDs while at the outside, including amputation of his left index finger tip. So the reason that he had actually gotten transferred was because of the significant tissue loss. The orthopedist there had talked to him about need for amputation of his hand, and he wanted a second opinion. So came here and saw our orthopedic docs, who took him back to the OR again for 2 additional INDs and then graft placement. The only other thing of note was he had been on clindamycin prior to this for a couple of weeks for a sinusitis. Kind of scrolling through his medical and surgical history and medications, of note, diabetic, coronary artery disease, and some underlying CHF. Aside from that, no real allergies to any antibiotics. He lived with some extended family, and his discharge plan was to go to an acute rehab or a SNF for some additional physical therapy. His labs kind of show how significant his infection was on initial presentation. So that white blood cell count of 34. He also had some end organ damage with a creatinine 2.4, some transaminitis. By the time that ID was consulted, his labs and things were back to baseline. And then micro-wise of note, so repeat OR cultures here had shown some gram-positive cocci. We had been told that there were some gram-positive cocci on OR cultures at the outside, but blood cultures were negative, although they had been obtained after antibiotics were initiated. And in terms of imaging, really just diffuse skin soft tissue edema was noted on a CT scan on initial presentation. So he had already had a PICC placed. Antibiotics had just been adjusted slightly from vanc, cefepime, clindamycin to vanc, cefepime, and flagyl. And ID was called more to kind of bless the regimen and say that he likely needed a 6-week course. So the questions I kind of propose are, okay, does the patient still need polymicrobial coverage? And does he need a 6-week duration? Any questions or concerns so far after kind of presenting things? Great.
Did you need me to bring those images up? So sorry.
Oh, yeah. That would be great. Thanks, Elizabeth. Again, Elizabeth will show the images. What's cool about them is just like we don't have the pictures from the outside, but just show how significant his surgical intervention had been. You can see as a wound vac on and in the first picture. And then if you don't mind going to the second picture, this is actually more when ID was consulted. So now he has this graft of his hand placed, is kind of status quo, getting ready for discharge. And we're just called in to kind of bless the regimen. So one of my favorite things about being an ID doc is you often are called in kind of into a hospitalization, and you have all these like pieces of a puzzle that you put together and then can say, this is the diagnosis. And everyone's like, oh, how'd you know that? And you're like, well, all the work that you did, I get to kind of look back on and as you all know, hindsight is 20/20. So how I would classify this guy is as a necrotizing skin soft tissue infection, likely with some toxic shock syndrome. So when he came in, he was multi-organ failure, hypotensive. That polymicrobial regimen that he started on was definitely needed with the clindamycin, kind of thinking of that toxin treatment. If you look at our antimicrobial stewardship guidelines, we actually trade out that with linezolid, again, for gram-positive and toxin treatment. When we called the outside, he ended up brewing kind of your classic strep pyogenes or group A strep, which is known to cause necrotizing skin soft tissue infections. More so than that, are less often seen, at least at our institution, than more of a necrotizing infection that you see in maybe a patient with uncontrolled diabetes, where they have a perineum polymicrobial infection. When we did get his sensitivities, it was actually resistant to clindamycin. So we ended up adjusting them to ceftriaxone for planned 2 to 4 weeks, knowing that his repeat cultures from the OR had still shown bacteria. We wanted to give him a good couple weeks on antibiotic, also knowing that he had a PICC line in place and was going to a skilled nursing facility. Any questions or comments on that case?
Thank you so much. Any comments? Great job. Thank you so much, Jess. All right, and if there aren't any, we can go ahead and move to the didactic portion. Drew, did you want me to share your slides, or did you want to do so yourself?
That's fine. You can share it.
Just let me know when you want next slide.
Thank you all for those couple of cases on when we would consider additive antibiotics or combination therapy. I think I'm going to touch a little bit with one of the examples that I pulled on Jess's scenario and necrotizing skin infection during my brief presentation, but we can go ahead and move to the next slide. Our objective today are just going to recognize a couple of indications for which combination antimicrobial therapy could be appropriate. Next slide. So the very first thing I wanted to talk up was something that we have seen. I should say all three of these disease states or indications are more managed on the inpatient side of things, certainly up front, but several of them are pretty common, at least in our practice, due to the high degree of infective endocarditis patients that we see, local rates of IVDU and whatnot. The very first thing is the concept of Staphylococcus aureus bacteremia, and what's defined as persistent Staph aureus bacteremia. So we recognize Staph aureus as a difficult pathogen or a prominent pathogen in a number of pretty severe deep-seated infections, things like infective endocarditis, other bone and joint infections for sure. And thus there is some concern if a patient subsequently develops positive blood cultures after initial positive blood cultures on, are we correctly addressing the bacteremia, and what things can we consider to manage it most effectively? The very first thing I wanted to share was this definition of persistent Staphylococcus aureus bacteremia. Historically, and what's been published in the most recent IDSA guidance document from about 6 or 7 years ago, they define persistent Staph aureus bacteremia as blood cultures that are positive with Staph aureus for at least 7 days. More recently, and say the last 5 years or so, published data defines or suggests a redefining of that notion with 3 to 5 days on active antibiotics, 3 to 5 days, and this was largely due to more antibiotics that came on the market with activity against Staph aureus. So really, we were looking at things like vancomycin, daptomycin, linezolid up front. Certainly now we have our longer-acting glycopeptide agents, some more novel fluoroquinolones that we don't use a ton in the treatment of Staph aureus. But that was the basis of the proposal from this review article from which I published, or included that statement there in 3 to 5 days. More recently, just as of last year in November of 2022, another review article was published that even suggested we consider any subsequent positive blood culture that's been collected the day after initiation of appropriate antibiotic therapy can be considered persistent Staph aureus bacteremia. So really the trend being over time, the day period is getting shorter and shorter when we could be considering these complicated infections. So next slide. Why does this happen? As the authors of that article in 2022 stated, a lot of times it's due to an unidentified foci of infection. So any subsequent positive culture should certainly prompt evaluation of that patient for these complications. So that might include a TTE or a TEE or evaluation of endocarditis, imaging of the joints or spine, if a patient presents with bacteremia and say certain joint pain or back pain. Ultrasonography of the vascular catheters in place, or an abdominal or pelvic CT that could help tease out if there's any metastatic emboli that's concerning for infectious emboli somewhere in the abdomen pelvis. Next slide, sorry. So the authors of that article, and in addition to that, the guidance that we use here at WVU Medicine in our practice site at Ruby kind of follows this stepwise approach. The first is making sure we optimize doses of the antimicrobials the patients want up front. So that's correctly dosing the medication for renal dysfunction or lack thereof. We know that's the case with a number of our beta-lactam antibiotics, as well as things like vancomycin and daptomycin that could be used as initial therapy for Staph aureus bacteremia. If that approach doesn't work around that 3 to 5 day mark, then we recommend alternative or combination therapy depending on what organism is growing. If the isolate is determined to be methicillin susceptible, that means we wouldn't need something like vancomycin or daptomycin. Say that could necessitate a switch from something like cefazolin up front to maybe oxacillin or nafcillin, depending on which agent's on the formulary. In the case of MRSA, our recommendations are to actually combine either one of those first-line IV agents for Staph aureus bacteremia or MRSA bacteremia with ceftaroline. So you can see up here on the slide that's daptomycin plus ceftaroline or vancomycin plus ceftaroline. Interestingly enough, before this article was published that I've referenced from last year, our stepwise approach included a similar management strategy for MRSA where we might switch, say, from vancomycin to daptomycin alone, or daptomycin to vancomycin alone, depending on what was started empirically. But observations that were published recently have found that a switch in monotherapy does pose the risk of development of resistance to that subsequent agent, and thus recommendations that we're making are to include a dual combination therapy after a persistent diagnosis is made. And then currently our standardized practice, or our WVU Medicine guideline-based practice, is to transition back to monotherapy after 72 hours of clear blood cultures. But that leads me into the next slide, which I just wanted to kind of gather from the audience. What's your approach to treating persistent Staph aureus bacteremia? I know my experience with rounding with a number of different infectious disease physicians here, the approach can certainly vary from practitioner to practitioner and patient to patient. So I was just curious if anyone had any input from the audience on what they've done in the past for their strategy.
Yeah, Drew, I think that was all good points. I know sometimes I take some patient factors into consideration. A stable patient, as we sometimes get, especially younger patients with MRSA bacteremia, who are doing well on VANC and maybe going to the OR really soon, even if they're meet criteria to do combo therapy based on duration of bacteremia, sometimes I'll just write it out. Versus my older patient who might be more of a medical management patient, I tend to pull the trigger a little bit quicker on trying to use combo therapy for a MRSA in order to sterilize their blood, just because their reserve is a bit different. But happy to hear what other people kind of think or do.
Thank you for that, Jess. Anybody else?
We can move on to the next topic within this session. So this is what I was referring to as somewhat relating to Jess's case she presented earlier. And that's talking about necrotizing fasciitis. This is an infection causing necrosis of muscle fascia and other subcutaneous tissues. Organisms that are often implicated in this complicated skin soft tissue infection are Streptococcus pyogenes or group A streptococci, MRSA, Aeromonas, hydrophilia, Vibrio species, and many times these infections can be polymicrobial. Next slide, please. I wanted to highlight group A strep in this particular instance, or Streptococcus pyogenes. It and as well as MRSA is capable of exotoxin production that can cause severe systemic complications. Historically, for a very long period of time, clindamycin was standard of care as adjunctive therapy to prevent exotoxin production. More recently, and as Dr. Johnson alluded to, linezolid has been advocated for largely due to high rates of group A strep clindamycin resistance. Here locally, in our community, it's estimated that among streptococci or group A strep isolates, over 80% of them that we observe in our microlab are resistant to clindamycin. And as such, we can go on to the next slide. These are what we currently recommend for empiric therapy in cases of necrotizing fasciitis. So we're taking that linezolid component, which addresses both concern for exotoxin production and also covers a large number of gram-positive organisms that could be implicated. And then adding something with a little bit broader gram-negative and anaerobic coverage. So that might be permethrin tazobactam or a combination of cefepime and metronidazole. I wanted to ask or pose the question to the group again. Next slide, please. When do you consider discontinuing anti-exotoxin therapy in the case of necrotizing fasciitis? This isn't a well-defined principle published in literature or guidelines that are available, and I think it varies from place to place, and certain in this case as well, maybe patient to patient. I was curious on what others thought about discontinuing, say, adjunctive clindamycin or transitioning. In the case of linezolid, they might remain on that agent because it offers good coverage of causative organisms. But thinking strictly about anti-toxin therapy, when would you consider discontinuing that agent?
The audience. So there we go. Okay, Katie.
Yeah, Katie's saying after 48 to 72 hours. Yeah, I think that's probably something that I've seen quite frequently, certainly after say someone's underwent good source control 48 to 72 hours, and they're clinically stable. Some of these patients who present with this infection remain in the ICU, surgical ICU, for quite some time. And so I've seen toxin therapy extended for longer than, say, what you might typically consider, but 48 to 72 hours sounds crazy. Anyone else?
Like you said, good source control, right? So shorter duration with good source control.
Yeah, like what Joy was saying. I think this is like your infection where you really should be talking to your surgeon because they're going to be able to tell you like, hey, I'm not taking this person back. Like I got all the necrosis out, the infection is controlled versus, you know, they're still intubated in the ICU with end organ damage, and there's plans to return to the OR for some more debridement. I might hold off on stopping the like additional antitoxin antibiotic.
Thank you all. Awesome. I had one more scenario to present. It's a little bit shorter, but was curious on what the group might be able to offer. It's cases of gram-negative infective endocarditis. So this is a disease that really doesn't have much in the way of officially published recommendations. I pulled for you two examples here. The first, and when I'm talking gram-negative endocarditis, I'm thinking about pseudomonal infections or enterobacterales, including things like Serratia marcescens. The IDSA in 2015, their most recent endocarditis guideline update, recommended among a brief of a few other recommendations to administer combination antibiotic therapy with a beta-lactam and aminoglycoside or fluoroquinolone for 6 weeks. That's reasonable. Next slide, please. Just this year, the European Society of Cardiology also revised their own infective endocarditis guidelines, and unfortunately didn't offer much more in the way of do we target specific organisms with duplicate coverage of their specific scenarios like prosthetic valve or certain organisms in which combination therapy might be more appropriate. Here they say recommended treatment is early surgery plus prolonged therapy with combinations of beta-lactams and aminoglycosides, sometimes with additional quinolones or trimethoprim sulfoxazole. So I wanted to pose one more audience question. What's your approach to gram-negative infective endocarditis if you've encountered it previously? When would you consider duplicate, or not duplicate therapy, but polymicrobial or double coverage for these organisms?
Feel free to chat in or unmute, please.
Okay, if not, it's definitely a complicated scenario. I can share a couple of examples of what I've seen in our management here. Occasionally administered complicated therapy with, say, cefepime and a fluoroquinolone like ciprofloxacin in the case of a pseudomonal infected endocarditis. Or maybe cefepime plus an adjunctive aminoglycoside like gentamicin or tobramycin. One thing I did want to highlight with this this particular topic was, and this is a little into the weeds, but the CLSI, the governing body who provides MIC breakpoints for a number of or for North American microbiology laboratories, recently decided to get rid of their breakpoints for gentamicin and Pseudomonas aeruginosa. And so where that may have previously been used as a double covering agent, based on that principle, we feel pretty strongly if there's going to be a concomitant aminoglycoside on board, alongside a pseudomonal infection, maybe in the case of endocarditis, tobramycin would be preferred, or one of the fluoroquinolones. That's all I had. If anyone else had anything they wanted to say.
Thank you so very much. Go ahead, Jess. Sorry, I thought you were.
No, that was great. I know when I see a gram-negative endocarditis, my first call is to the surgeon, but that I hadn't realized that about the CLSI guidelines and things. So awesome point, Drew.
Thank you all.
Thank you so much. Does anybody have any following questions or examples they'd like to present? All right, gave you that long echo pause. Yeah, please do feel free in the future, unmute, and this is a safe space. We like to interact with everybody. So we really appreciate everyone's time. And thank you for tolerating me as Jay's out. And the next time we'll meet, it looks like it's going to be January 9th. So we hope you guys have a really great holiday, and please reach out for any questions or concerns you might have in the meantime. Thank you.
Yeah.
Thank-
Thanks, Jen.
Thanks.